The ultrasound fan originating from the probe creates a 2D picture on the screen. How we rotate the probe determine how we visualize the vessel in this 2D picture. Now the vessel is essentially a long tube. If we place the plane across the vessel, we get the short axis view, and the tube appears as a circle. If we place the plane along the vessel, it's called the long axis view, and you see the length of the tube. The vessel appears as a horizontal bar. There's also a middle way, the oblique view. It's obtained by going halfway between short and long axis. We'll get back to you why you need to master this in just a little bit.
The right side of the neck perpendicular to the skin. The vein is usually located more lateral and more superficial to the artery. If there is any doubt, try compressing the vessel. Rotate the probe to a position halfway between the in-plane and the out-of-plane view. This is the oblique view. If we superimpose the IJV, you can see how we slice it at an angle. This allows for an in-plane approach to the vein while still maintaining a view of the artery, thereby minimizing the risk of accidental arterial puncture. The angle of the cannulation also allows for greater comfort for the physician, who can stand at the side of the patient during the procedure, but more importantly for the patient, who gets a central line further away from the face. Now prep a large area of the neck. While waiting for the chlorhexidine to dry, prep your tray. Place your equipment in the order you will be using it, and make sure to loosen all needle covers. Everything should be easily accessible by one hand, since you do not want to move the probe once you've located the perfect ultrasound view. Drape the patient. Position the probe close to the clavicle. Locate the vessel and rotate the probe in order to get the oblique view. Place the vein medially in the picture so you're able to see the cannula approach path. Inject local anesthetics superficially a few centimeters from the probe. Make sure to cover the point of cannulation and where the sutures will go. Then inject towards the vein. In this case, a bent needle was used to accommodate the patient's anatomy, but this is generally not required. Use the empty 2 cc syringe as an improvised handle and place the index finger along the cannula to facilitate lateral displacement. Advance the cannula towards the vein in a continuous motion and proceed only if you see the needle tip. Aspiration of dark, non-pulsatile blood indicates successful vein puncture. Be careful to cover the bore and insert the guide wire in the usual manner. Now confirm the position by increasing the depth to 10 centimeters and placing the probe along the short axis of the vessels. The guide wire should be seen as a hyperechoic dot in the IJV, here circled in red. Now tilt the probe caudally and follow the guide wire as it descends towards the superior vena cava, marked in blue. An adequate depth has been achieved when the tip reaches the level of the pulmonary artery, marked in red. Be sure not to confuse the guide wire with the hyperechoic pleura of the right lung, marked in green. In our opinion, this confirmation of the guide wire position is the main advantage of the microconvex probe. Proceed with the central line in the usual manner and further confirm the venue's placement by observing the height of a non-pulsatile blood column. We're currently performing a validation study where we hope to show that the post-procedure X-ray is redundant if correct in-plane technique is used and the guide wire position is verified with this method. For more videos on anesthesia and critical care, please go to interanest.org.